Rally your NICU friends and join NAN at a discount. No matter what institution you're a part of, NAN provides discounts to those who join together. Groups of 3 to 9 save $10 on each registration, and groups of 10 plus save $20 each. The more friends you gather, the more you save. Take advantage of this discount today at nan.org/join. Please note that all members must be a new NAN member to qualify. Hello, and welcome to NANcast. I'm Jill, your host. As NICU nurses and APRNs, we are often confronted with the challenges of caring for infants affected by maternal substance use. This issue not only affects the health and development of the newborn in the NICU, but also has a profound impact on their future. How can we, as NICU nurses, balance our responsibilities to protect and support both mothers and their babies? In this episode, we'll explore the complexities of maternal drug use in the NICU setting, including the latest statistics, the importance of compassionate care, and the role of mandatory reporting. I am joined by Dr. Kelly McGlothen-Bell, a leading nurse scientist in policy focus, implementation science, to reduce health disparities, improve health equity for families at the intersection of reproductive justice and substance use. She dedicates her work to the protection and promotion of respectful maternity and neonatal care, reproductive justice, and health equity for all mothers and birthing people and their infants through advocacy, education, practice, and research. Dr. Bell will break down the statistics, nuances of mandatory reporting, the challenges it presents, and the implications for both mothers and their infants. So join us as we delve into this important topic and explore how we can provide the best care while addressing the challenges faced by families in the NICU. Let's get right into it. Thank you, Kelly, for joining us today. I think all NICU nurses have exposure to NAS babies, and we all realize that there is, unfortunately, a stigma surrounding the care of our NAS babies and their families. With your article, you took a different view on that. So instead of focusing on the care of our NAS babies, we talked about a broader subject on caring for the family as a whole. Can you tell us what made you decide to take that direction?
Sure, I'd be more than happy to. So by training, I am a mother-baby nurse, but I've always been in all of the NICU. I've done lactation consulting and worked in the NICU in that respect. And so when I look at care for our mothers and babies, it is dyadic. There really isn't a separation of the mother and baby. But specifically when we look at babies who have NAS and those families who are affected by NAS, we tend to see that there is that innate separation that typically occurs. I've been a nurse for almost 12 years now. And when I went into nursing, that was really at the height of the opioid epidemic. And unfortunately, I don't think we really knew how to care for these moms and babies. Again, there was a lot of separation. These babies went straight to the NICU. And oftentimes moms, unfortunately, weren't made to feel as welcome as they should have been into that space. And unfortunately, we still see that happening today. And so I think that as a nurse, whether NICU, mother-baby, specifically if you're working with families, you have to really consider the needs and the considerations of not just the baby, but the mother, the parent, the dyad, the family as a dyad, in order to offer the best level of care that we can.
Yeah, I agree. There are so many care complexities to care for these babies. And, it's difficult to care for a baby in the NICU that has a very healthy, supportive relationship family. But then now we're having that challenge of supporting both the baby and the mother that has many other challenges that she's facing in her own recovery and her health, and also the stigma that is around what she is experiencing, not only in this healthcare environment, but also in the community.
Most certainly. Yeah, I think that's something that's oftentimes lost, is this notion that really the idea that we care more about this baby than the mother does. In the work that we've done in the past, one of the most prevalent things that I hear from mothers is this innate guilt already, for one having a substance use disorder, but then their baby is being affected by that substance use disorder. And so I can tell you no one feels worse about that than the mother themselves. And so they carry that internal guilt, but then they also get that from the interactions that they have with healthcare providers. But then when they're out on the outside, not just from people in that external community, but even from their own family members sometimes. I think oftentimes when we think of substance use, we equivalate that to it being an intergenerational problem. And yes, oftentimes it is, but there's many families that I've talked to that said, I didn't grow up like this. Like substance use was not an issue in my family. And so they almost become the black sheep at times, whether substance use was prevalent or not. And so they're carrying a lot within that as they're coming in every day. And so it takes a lot just to show up many times to the hospital because they don't know what they're going to get when they get to the bedside.
I think we talked about the views of the community, their extended family, but also there's a whole nother aspect of having mandatory reporting where these parents are facing social work intervention, any kind of child protective services that now get involved. So that puts an even higher stigma on that family. And I feel that could increase a lot of their anxiety and that feeling of disconnect, like you mentioned, with their baby.
Yeah, I totally agree. I think for many of us, you ask almost anyone, they've had some encounter with substance use, whether it be themselves or a family member or a friend. And from those lived experiences, we come to formalize our own biases about substance use and what that looks like. And so I can imagine that if I were to ask you, like, picture someone with a substance use disorder in your head or with an addiction in your head, we likely can think about probably a very similar person. And that's largely from our lived experiences, but also the media and the role media plays in terms of the manifestation of what someone with a substance use looks like. And again, that really bleeds into our level of care at times. And oftentimes we really don't even know where those biases come from, but they're largely rooted in our history as a country. Policies related to drugs and the war on drugs date back years, starting in the early 1900s. We saw the enactment of acts like the Harrison Act in 1914, the Marijuana Act, and these were legislation and policies, bills that were put into place with the idea of protecting us from drugs and substances, but they innately also had some blowback where largely families who were either Mexican American or Chinese American were largely targeted in terms of the enactment of these laws. And that kind of stereotype, that stigma has bled over into the 80s and 90s, where we saw, again, the war on drugs and this proliferation of the idea of the crack mother, which was largely targeted for Black and brown women. And a lot of us grew up in those eras. And so we're very, very keen on what that looks like and what the crack mother looks like. And so unfortunately, although we may not always explicitly see that bias, it's within us, and that goes for anyone, I believe. Like, that doesn't matter your race, your creed. I think we all have those biases that we have to be aware of, and that can really play a factor in which families get reported to CPS, the CPS outcomes in terms of child removal, even moving back into things that initiate the start of mandatory reporting. So going back to drug testing, we see that families of color, those with little prenatal care, those of lower socioeconomic status are typically the ones who are selected for drug testing. Even in cases where universal drug testing is a policy, that has been an issue. And that bleeds into the larger implications of seeing large racial and ethnic disparities in terms of the babies or infants who get removed from their homes.
Do you find that with universal drug screening, that's a hindrance and also increases this stigma and these implicit biases that people in the healthcare field, and especially mother, baby, and the NICU have? Or do you think it's better to have universal drug screening almost to sort of, I don't know, even the playing field, so to speak?
Yeah, and I have to back up because I made the mistake of using the word screening. There's a differentiation between testing and screening. So largely when we think about testing, that's something that's done with a biological sample, usually the urine or the blood or hair or meconium, versus screening, which is a conversation that's had using a standardized screening tool. And so largely when we think about universal testing, which has historically been the case, or what hospitals have moved towards, the issue that we sometimes see with this is that it's done without informed consent for the family. And so although everyone's getting this as a blanket level of care, no one's being told that it's being done, and then no one's being told what's going to happen with the results from the drug testing. And so I've talked to many and interviewed many mothers who said, I didn't know that I was being tested. I wish I had known. I would have, I may have been more likely to be open with my substance use, but by them doing the testing and not telling me what was happening, that made me just want to leave. And so that's a missed opportunity to really engage that mother, not only in care and services for herself, but also still in the care for her baby, and maybe her talk a little bit more about, what led up to the substance use. And again, they're not being told what happens with those drug testing results. And so oftentimes those tests or the results are sent to CPS or to social workers, which leads to CPS involvement. And so I think that brings in part a very large ethical issue. Especially for us as nurses, we're kind of the intermediaries in this space. And so that can jeopardize the level of trust that we have with our patients. And I think that's a really major consideration that we don't really think about sometimes when it comes to just initiating a test or asking, why are we doing this test?
That's so true. And I think you brought up a great point, too. If we're doing universal drug testing and we're telling these parents, then maybe we can start explaining to the moms what to expect when their baby is born. Because I think there's an extremely lacking of communication for what the moms should expect when they're delivering a baby, that when they're dealing with substance use disorder. And we could start that from the beginning,
exactly,
prenatally, and hopefully that'll help build some of that trust back up between the nurse. I feel like oftentimes it's a us nursing versus a parent thing, and it's very they think that the scoring is very subjective, and I hate to say this, but they feel that maybe we're taking it out on their baby because of what what the mom is going through. So I think that would be a great opportunity for education prenatally.
Yeah, you bring up a really important point, Jill, and the need to build and establish that rapport with patients. And that often starts prenatally. But if we can't get patients into care, if we are not building these systems or structures that make them want to utilize prenatal care services, then again, those are missed opportunities for building that rapport, but also ensuring they're getting the necessary care they need, both obstetrically and for their substance use disorder.
So these policies that are out here for mandatory reporting for CPS, that really affects our family-centered care. And I don't think that's something that we as nurses think about, because all of our focus, you mentioned earlier, is about the care of the baby and how we can best manage their withdrawal. But we don't hear much about how that mother-infant dyad's affected by these CPS reportings and all the policies that are built around that.
Yeah, for sure. I think, when we think about reporting, we think it's a one-stop shop, and oftentimes we don't do the reporting specifically. We report to our social workers, and they do the reporting. So it's almost like we're removed from that situation in a sense. We don't get to see the long-term implications of that. But you can bet that when a mother's been told that she has been reported to CPS, she's probably less likely to come back to the hospital because she doesn't feel safe in that space. And so again, those are missed opportunities for us to engage families and family-centered care. And I understand that oftentimes, if there's a true concern for the welfare of this child, then yes, a report has to be made, or, there has to be something done. But I don't think we oftentimes have a clear understanding of when these types of reports need to be made. So I think it's really incumbent on the nurse to understand what are the policies in her state. How do we define child abuse? Not every state defines substance use as a form of child abuse. And I think it's important for nurses to be aware of whether or not their state does define substance use as a form of child abuse. So I think it's important for us to have a definition for child abuse so that we're all on the same page. So child abuse includes any form of neglect, including not providing for the physical, emotional, or health needs of an infant or child. This can also include physical abuse, psychological abuse, sexual abuse, really anything that causes harm or risk of harm to an infant or child. And I think something that, again, to be of note is that historically the conditions of child abuse and neglect have been treated synonymously with this idea of substance use during pregnancy, and even the idea of poverty. They've been quantified as forms of child abuse and neglect. I oftentimes say having a substance use disorder isn't a measurement of a parent's ability to take care of their child. It's just a disease that they have. And so we have to ensure that they're able to have access to the services they need so they can take care of their babies. But we can often work really hard to create a space where even if there is going to be CPS involvement, while those families are in our care, they feel welcome. They're able to form bonds and attachments with their babies. Um, I've talked to mothers and fathers, and they've said that nurse just being kind to me that day, like it made all the difference, and it made me want to come see my baby. It made me feel empowered to advocate for myself and for my baby. And that although we might not think about it, it really does trickle into the care that happens after those babies leave the hospital. And that can really help to set up a mother and a baby for, a lifelong bond that they may not have had before.
You bring up a good point as nursing, not knowing the state policies or, whether or not it has to be mandatory reporting, because we do kind of work in silos. Social work does it. We get and report, oh, CPS is involved. But at that point, we don't really understand what that means to the greatest extent, obviously, as the mom does. And I think nurses unknowingly think negatively of the parent because they're not visiting, and they think that is like a strike against them, but we don't realize that they're not visiting because they're anxious that every little thing they do is going to be reported. The nurses might not know that this mom is, in jeopardy of losing custody of her child because it was reported.
Yeah, I think that's a great point. And I think we can do a better job of just asking the mom, what are some of the barriers you have to coming, to the NICU, just like we might do for any other family. But I think oftentimes we forget that many of our families that have a substance use disorder or that are affected by substance use have a lot of competing things that are going on in their life. I can guarantee that for the most part, if they had the choice, they're going to be there at the NICU with their baby. But as you said, they're dealing with their own recovery. So that means hopefully they're engaged in some type of medication-assisted treatment or medication for opioid use disorder. So they're having to go to their clinic to receive their medication, which means waiting in line, waiting till the medication's available for them. They may have to see a physician or a nurse after that for after treatment. If they have other children, they're engaging in childcare. If they have jobs, obviously they have employment obligations. And then for some of the families that we work with, they also have other criminal legal dealings they have to go through. And so that leads to them having to do maybe drug testing or mandated parenting classes. And I think one thing that we don't often recognize is that even outside the hospital, those systems are functioning within silos. And so oftentimes they have competing schedules. So I've had moms say, like, I have to go do my drug report, report for drug testing, but I also have this mandated parenting class scheduled at the same time. And if I don't show up to either one, then it looks bad, and that's a strike against me, and that may be the determining factor of whether or not I get to maintain custody of my child. And that's no fault of the mother. Even, working with navigators or with CPS workers, I've heard at times there's still not that advocacy to say, like, hey, can I call this person and say, like, I have this other class happening at the same time? And so I think we as providers, in whichever sphere, can do a better job of advocating it and really just showing that these parents are trying, and being that voice where maybe their voice isn't being heard.
Balancing their own recovery and then trying to be present for their child must be, very daunting for them. Like you said, trying to make that decision. Some places where I had worked, there's a program where moms are in recovery and it's very strict rules. So it's limiting their visitation when they can come and see their baby. So, that is a struggle for moms. And we have to think, okay, all right, you can only come these so many days, these many hours. How can we as a team make those hours that you're visiting the best?
Yeah.
Let's learn feeding, let's learn baby care, all of those things. So, instead of being in our little silos, we do need to make it more multidisciplinary and have those conversations amongst all the teams.
And I'm glad you brought up those interventions that we do. So like the skin-to-skin care and the breastfeeding, I think sometimes we forget that those activities are just as important for babies who have NAS or NOWS as any other baby that's in the NICU. And oftentimes they can be, I don't want to say more important, but just as important for those babies. We know that the consumption of human milk for babies who have NAS lends to better health outcomes. They tend to get out the NICU a lot quicker. That also helps to reduce mom's stress when she's able to do skin to skin with the baby, and help with bonding. So those are just, you know, typical care activities that we do with babies in the NICU that sometimes, again, for reasons, whether it's stigma, or maybe the mom's not able to be at the bedside all the time, or the dad's not able to be at the bedside all the time. Those are activities we really should be cognizant of and really be advocating for with those families especially.
You mentioned that outcomes after the hospital and when they leave those NICU doors, as far as having the active involvement of child protective services and the stigma and the challenges around that. So what have you found in your research as far as like how are these parents doing post-discharge from the NICU?
Yeah, so we did a study a number of years ago where we were interviewing families, mothers and families who had been affected by an opioid use disorder during pregnancy and the year following. So these were women who had experienced a return to use or relapse during pregnancy, or had experienced an overdose and recovered from that overdose, or family members who had lost someone to overdose from opioids during pregnancy and the year following. And in our focus groups and our interviews, one of the number one risk factors or main contributors to that relapse or overdose was having CPS involvement. And that wasn't just, again, not just having the removal of the child, but just having CPS investigate them was a main stressor for them. And so I think we have to really ask ourselves, are we doing more harm to these families by involving CPS when we don't know what the outcomes are going to be? Specifically, if we are not positive that there is any harm being done because of the substance use disorder. And so when I say this, I think it's really important for people to be aware of that our laws under CAPTA, which is our main law regarding mandatory reporting, they don't necessarily say that a person who has a substance use disorder or who's engaged in treatment for a substance use disorder has to be reported if there are no other concerns for the health and well-being of that child. What they do say is that we need to be ensuring that these families are getting services. And so they're reported for service needs, not so that there's an automatic removal of a child. And so I think we really have to do a deeper dive of the policies that are currently in place at our state level, at the national level, and how they're being implemented locally, to understand, are there some areas where we're not truly understanding the intention behind this policy, and are there ways that we can ensure that these policies are being enacted or implemented equitably amongst families, so that they are actually getting the services they need. If someone needs substance use treatment, then we can do that for them. That doesn't necessarily mean that baby needs to be removed automatically. If they need assistance with housing, that doesn't necessarily mean that baby needs to be removed automatically, but are there services that might help them to get stable housing, or go to maybe a recovery support outpatient service that has a bed for a mom and a baby? Those are popping up everywhere, and I'm loving seeing these coming up because we know that the research actually shows that families have better outcomes when they're able to be kept together.
In your research, do you have some statistics on mandatory reporting and the characteristics of different families that are involved in child protective services?
Yeah, sure. I think one of the more overarching ones that we can be aware of is that 31% of births actually occur in states where there are mandatory reporting laws. So likely if you are a nurse, it's something you want to be aware of. I mean, every state has mandates nurses, social workers to be mandatory reporters, but only 31% actually have a law related to that. And so I think it's important, again, to be aware of whether or not your state has a law. But I think in terms of the families that we come in contact with, I think it's important to know that infants are the largest growing population within child welfare. So those are the babies that we're seeing on a day-to-day basis. And about 50% of child removals are actually related to substance use. I would say about 10,000 infants enter the child welfare system annually due to substance abuse issues. And so it's important to be aware of the families that we're coming into contact with. Again, are they truly needing CPS services? Are they needing services that we can get to them without having CPS involved? Or do they truly need to have the more surveillance because of their necessary needs? But we have to be cognizant of what that may also mean for that family. But again, across all 50 states, nurses are considered mandated reporters. And so, again, I think it's important that we be aware of how our states quantify child abuse as it relates to substance abuse. So I think it's also important to be aware of those racial disparities that we see within child welfare. So we know that there's an overrepresentation of Black and Brown families within child welfare. And specifically, about 23% of children in foster care are actually Black. And that only represents 14% of our general child population. And so again, we have to ask ourselves, how do the identities of the families that we're working with overlap with stigma and discrimination? Families, again, who may come from a often stigmatized or historically marginalized background may be more likely to be reported to CPS than some of our other families. And we have to ask ourselves, what role do we play in that proliferation of these health disparities?
Hearing all of these statistics that you just mentioned and the profound impact that it has on the babies that we care for every day, what can we do not only in the hospital, in our NICUs, but outside in the community to help these families and their babies to have the best outcomes possible? Because we know this is affecting them well beyond the NICU doors.
Yeah, I think that's a great question. One area that I love to see nurses involved in and even getting more involved in is policy. I think we don't understand the power of our voices and the role that we can play in terms of ensuring that policies are equitable for our families. And so I think that includes analyzing policy. So again, understanding what is a policy at your own organization, what is your policy at the state level, and this can be related to mandatory reporting, child welfare, substance use, but also a number of issues that you may face in the clinical setting. And you have the power to do that analysis and to evaluate whether or not the outcomes that were intended for that policy is actually what's happening. You can also partner with legislators and enact bills. You can help provide evidence. We have the background and the knowledge for these different health issues that we're facing, and we can help support and advocate for bills that may help target families that are in our purview. I think other areas may be research, and I know sometimes not all nurses see themselves as researchers, but we are, and so that could be partnering with your research team at your local hospital. I think we need to have more researchers be a part of that team, and invite the families that we're working with to be a part of those research teams, because they have the innate knowledge that is necessary to really create and co-create tangible interventions that will have better outcomes for them themselves.
I love that, including parents in research. And especially as a nurse, you are having the most connection with these parents every day. And you can hear what are their struggles. And then that's amazing data that you can provide to the policymakers on an upper level, because you can speak their lived stories and you can tell them what struggles and challenges they're facing and how this is affecting them and the outcomes outside of just that infant state. But, when they're growing up in childhood.
Oh, yeah. I think sometimes we forget that policymakers are not experts in our area, even though sometimes they try to make it seem like they are. We are the experts in healthcare. Again, families trust us. It's a reason why nurses are number one in terms of trusted health professionals. And so, again, when we can't have families in the spaces to co-create those policies, or maybe to testify upon for certain bills to be passed, we can be in those spaces for and with them to ensure that, like you said, their voices aren't lost.
And we're such a large group of people that we can very well be heard by the policymakers and the people that need to hear our voices.
Yeah, and I think that's a really big push for why NAN is so important, why our professional nursing organizations are important, because we have a collective voice. We just have to use it.
Yes, and NAN has a whole advocacy group that is willing to have new members to join and fight for these families and these babies, and it's very important, and your voice matters. And I think we often don't think about how we can make change outside of the NICU, but we can. We have the power, we have the knowledge. We just have to get together and do it.
Most certainly. I couldn't agree more.
Overall, what are your thoughts on the best way a nurse can engage and support these families at the bedside?
I think this wisdom certainly comes from one of the mothers that I've worked with for a number of years. And she says very simply, be kind. And I think that's at the core of who we are as nurses, is to just exact kindness for every family that we come into contact with. Remember and keep central that they are humans first and foremost. They have feelings, no matter where they come from, no matter what they've done. And if we can remember that and just act and operate in a space of kindness, I think that goes a long way. There's new definitions for this or new terminology that we were hearing, like respectful maternity care, which I love. But again, at the root of that is just kindness and humanness, and just remembering that we all come from a place of love. And I think we just have to put that into everything that we do in our nursing care.
Thank you, Kelly, so much for joining us today. I hope everybody takes what we've learned, becomes very active in advocacy for these parents and these families, and ultimately help the outcomes of our tiny babies. So thank you so much. Make sure you never miss an episode of NANcast by subscribing now. This episode is made possible by listeners like you. Thanks for your support and letting us into your ears. Have a great day.